What are some of the tips and tricks you guys are using at Cornell? I'm going to share what we're doing at St. Francis in order to identify these patients, but then also to ensure that maintain eligibility.
Yeah, that's a huge trick because oftentimes these patients have multiple providers and we're not necessarily the main contact for that person. And when we see these patients, because we have just like you guys, we have a complex coronary practice, we're generally seeing these people for potential revascularization options. And after we've explored all of these things, we'll introduce these trials to them. And I spend a fair bit of time with them in the clinic explaining to them that, look, this is a clinical trial. We're looking for a specific type of patient. And to be qualified for this trial, we need to make sure that these conditions are met. And without getting into too much detail with them, we try to emphasize the idea that medical therapy is one of the main entry gateways to get into the trial. You need to be on medical therapy. So we make a big deal out of having them contact our office. We have nurse practitioners that help us with all of this stuff to make sure that we're keeping their file up to date in terms of the time. Because as you said, they have to be stable for at least a month. It used to be way worse. It was 90 days, which was an impossible task.
Yeah, we ran through the same issues because it wasn't us. You can imagine the scenario where a patient goes to the emergency department with chest pain. The emergency room physician sees that this patient's got refractory angina, and then to discharge them with doing nothing seems almost negligent. And so they'll increase the amlodipine from 5 to 7.5 and it resets the clock. And so what we've done is actually give the patients either the doctor's number who's championing the study at our hospital, it's 3 physicians, or we give them a pamphlet to actually hand to the doctor that says that they're eligible and waiting for COSIRA-II study. And in which case, the ER physician usually just calls us. And that's really, really helped and say, look, we're trying to get the patient in. They have frequent contact with our coordinators. So we get the coordinators to call them every couple of weeks. And that actually helps them stay focused. And also they need a point of contact if they end up having angina.
100%. They need to have some line of communication with the study team so that they can communicate if there have been any changes and give us an update if they're just not feeling well so that we can make the change.
So the trial inclusion is also very vigorous, right? So I found it interesting that you had to do 2 treadmill tests within a week that fit within a certain criteria, 2.5 minutes to 8 minutes. And they had to be ending up within 30 seconds or so of one another to really prove that there just, wasn't an effort relation, that this was actually a limitation in exercise based on coronary artery disease. But that's been tough too, right? To get patients with refractory angina to exercise twice within a week. Yeah. How are you handling some of that stuff?
That's been a huge deal. I think that was a source of a lot of screen fails because patients and the treadmill techs all have sort of this idea that we need to run you till you can't run anymore, which is really kind of not what we're trying to do. We're trying to get an objective measure of what your threshold for angina is. And that's a concept that's sort of foreign to what a treadmill test is typically done for. So obviously we don't want to do anything that would unnecessarily sway a patient to do something that doesn't really seem consistent. But I do make a point to tell the patient, look, we're trying to figure out what type of activity triggers your symptoms so that we know what to compare it to. And I make a big deal about that so that the patient understands this is what we're testing. We're testing how much of a change we'll see in your ability to go on a treadmill before and after we do this study procedure on you. And so that helps them to understand a little bit more about what they need to communicate to the treadmill tech. And we also tell the same thing to the treadmill tech that, look, we're not trying to make a diagnosis here. This patient has refractory angina. What we're trying to understand is what is the threshold for their angina? That's a very different question than what we typically would order a treadmill test for.
So I'm smirking because this was the first time I ever saw where our exercise treadmill tests were done in the basement of the hospital, because we basically kept having this issue where the techs would just stop the patients right away. And we had some techs were saying, keep going, keep going, keep going until you're basically falling off of the treadmill. And other techs were saying, oh, you have your first bit of chest pain. Oh, stop. So some of us actually, I went down to the treadmill and spoke to the techs and also the reporting physicians and reiterated this patient's going into COSIRA-II. The goal of this treadmill test is not to document the presence of ischemia. It's really to document their exercise tolerance. And so that totally changed the game for us. I remember, I'm laughing because of my first patient. So my first patient who was enrolled in COSIRA-II, I'd known for 9 years, Jai, and I had put 11 stents into him. I brought him back for an angiogram basically every year. Every branch was pinched. He had objective evidence of ischemia. And the patient went to the exercise and he basically went over the 8 minutes and 30 seconds because he said, Doc, I thought you needed me to, do as much as I possibly could. And he was trying like he was basically killing himself on there. He said he was having roaring chest pain. He actually screen failed out of the study for that. But a year later, I got him into the registry and he had an absolutely dramatic change in his symptoms. And so this is, of course, isn't unblinding because the patient's not enrolled in the study. But I'll tell you what's really interesting about him. He calls me up like 3 months later, all right? Again, I've known this guy 10 years. He calls me up and he goes, Doc, I'm having pain. And I'm like, oh, man, this, it didn't work, right? And I'm honestly really disappointed. And then he says, ever since I started running in Central Park, my legs are hurting now.
That's fantastic.
I said to him, what? And I said, it's your legs, not your chest. He goes, no, my chest, whatever that thing you put in me, that fixed me up. I'm fine. I'm running now. I'm jogging in Central Park. So
That's was a great story.
Sort of a great story. I've shared that story with the developer of the coronary sinus reducer, Shockwave, who've shown it on a number of occasions because it's one of my favorite cases.
Yeah. I've actually had a couple of cases in Cleveland that just did not want to be in the randomized trial. Just absolutely did not. They actually went off to Europe and got commercial devices put in because they just were so excited to be part of this, but didn't want to be in the trial. And so, that's been an interesting story in itself to follow up with these patients.